Hello, I am Dr. Babak Sarani, the Chief of Trauma Surgery at the Level 1 Trauma Center at the George Washington University Hospital. I will be discussing the guidelines and care involved in evacuation care, the last phase of TECC care. You should have already watched and should be familiar with the direct threat and indirect threat phases of care. The last phase of care is called evacuation care and builds upon the care that has been given on the high-threat environment up to this point. Evacuation care is defined as care that is provided when there is no external threat. Let me emphasize, however, that threats are dynamic, and you may have to switch between phases quickly depending on how your relationship with the threat changes. For example, you may be operating in a casualty collection point or triage treatment corridor in a parking lot outside of a building where a mass killing event has occurred, an area which you consider to be no threat, and therefore evacuation care phase, when you realize that one of the cars in the lot is actually a vehicle-borne IED. You have just moved from evacuation care back into direct or indirect threat, depending on how you perceive the threat. Remember, the threat is dynamic, not geographic. Again, to be in an evacuation care phase, there must be no perceived external threat. As a whole, the evacuation care guidelines are more consistent with traditional pre-hospital care, building upon and carrying over care from other phases. Additionally, evacuation care has additional specific emphasis on managing the injuries and physiologic conditions that we know will increase mortality, some of which we do not concentrate on during routine pre-hospital trauma care, as the conditions and focus are different. It is important to remember that the phases of care in TECC represent a continuum of care, meaning care starts at the point of wounding, continues and builds upon itself through the evacuation corridor, through the evacuation platform, the medic unit, police car, whatever it is, and then continues into the trauma bay. So, TECC evacuation care guidelines have implications in the trauma bay as well. There are some guidelines, such as blood transfusion and advanced pain medications, that depending on your scope of practice and protocols are not to be implemented in the field. Instead, these guidelines are written and included as considerations for care in the trauma bay. The TECC continuum of care crosses the threshold of the trauma center door. Depending on the high-threat scenario, you may never use evacuation care. For example, if you have waiting transport units outside and the wounded patients are evacuated from the building directly onto the transport unit and taken immediately to the trauma bay, evacuation care is not needed. Instead, the evacuation care guidelines are implemented when you have any of the following: delayed evacuation because tactical situation prevents immediate evacuation. There are multiple persons waiting for evacuation such that the demand for transport is higher than the supply of units. Prolonged evacuation in situations such as in wilderness or austere settings when there is a long horizontal or vertical distance to get to the evacuation asset. Or we have what's called an atypical platform. In the Century 16 shooting in Aurora, Colorado, all of the initial patients and half of the overall patient transports to the trauma centers were in the back of police cars with only police officers in attendance. That is an atypical platform, and that is where the evacuation care should be applied. The goals in evacuation care are, first, to maintain any life-saving intervention that was applied during indirect threat care or direct threat care. For example, any bleeding or airway management that was applied at the point of wounding should be continued on through continuum of care into the evacuation care phase. Additional goals in this phase include providing rapid and secure extrication to the appropriate level of trauma care and avoidance of any additional preventable causes of death. The principles of evacuation care. Number 1, reassess. Reassess every intervention that has been applied in prior phases of care. This cannot be overemphasized. At every point in the continuum of care, prior interventions must be reassessed. Tourniquets loosen. Pressure bandages come off. Airways occlude. Tension pneumothoraces develop. you must make sure every life-saving intervention is being maintained. There should be additional personnel, equipment, and supplies in this phase. Thus, you should utilize all of these to maximize care. Here is where you will have advanced monitoring, airway management, potentially even higher level providers. So leverage these resources to build on what has been done. Don't forget hypothermia. It is critical to prevent the casualty that is waiting for evacuation from developing hypothermia. And it is in this phase that communication regarding medical care becomes critical, especially between the team that rescued the patient from the point of wounding and the evacuation care assets, as well as the evacuation care assets in the trauma center. This communication allows for good understanding and documentation of what care has been provided. As a whole, the TECC guidelines for evacuation care are largely the same as they are for indirect threat care. This lecture is not going to repeat discussions of guidelines that are carried forward from indirect threat. Instead, we will focus mostly on those differences that come from the additional time and resources in evacuation care. Up until this point, there has been little, if any, mention of triage. Triage. The TECC guidelines are written such that there is no official triage in direct and indirect threat care phases, as the operational situation and threat make formal triage unlikely, if not impossible. This, of course, should be protocol-driven and discussed with your medical director. The TECC guidelines emphasize that triage should occur early in the evacuation care and should emphasize both priority of evacuation and destination of evacuation. The exact triage methodology you employ is not important and should be according to your SOPs. Just make sure to include proper destination for those patients such that there is good distribution of casualties to not overwhelm any one medical facility and to ensure that patients requiring specialty care get sent to the correct receiving facility. Triage for both destination and priority. The following are wounding principles that should be considered during triage in evacuation care. Soft tissue injuries are very, very common in mass casualties, and they may appear very severe, but as a whole, soft tissue injuries are not immediately life-threatening unless there is severe exsanguinating hemorrhage. Patients with controlled soft tissue injuries can be a lower priority for evacuation. Bleeding from most extremity wounds should be controllable with a tourniquet or a hemostatic dressing and pressure bandage. At this point in continuum of care, there should be complete hemostatic control from external bleeding. As long as external bleeding is controlled, there is no internal hemorrhage, and the patient is not in hemorrhagic shock, there is little risk in making these patients a lower evacuation priority. Casualties who are in hemorrhagic shock, even with controlled external hemorrhage, are critically injured and should have a high priority for evacuation. Casualties with penetrating wounds to the chest who have respiratory distress despite occlusive dressings and needle decompression should have a high priority for evacuation. Casualties with blunt or penetrating trauma to the face that results in airway difficulty should have an airway immediately established and should have a high priority for evacuation. Definitive airway control requires a lot of resources to properly manage and maintain. Prioritize these patients because they are critically wounded and they require increased resources and personnel on scene. Rapid transportation of these patients frees up personnel to care for other wounded. Remember, do not force a patient to lie down. Allow the patient to assume any position they want, as he or she naturally will position in a way that improves respiration. Do not force the patient into a position, especially flat on their back, that compromises the airway. Unconscious casualties with blunt or penetrating trauma to the head that has caused obvious massive brain damage are unlikely to survive with or without evacuation and should have a lower priority for evacuation. Casualties with blunt or penetrating wounds to the head where the skull has been penetrated, but the casualty is conscious, should have a high priority. This is the Gabby Giffords wound. This may be a survivable wound. High priority evacuation. Casualties with any traumatic brain injury, penetrating or blunt, that exhibit any of the red flag symptoms of herniation should be high priority for evacuation. Red flag symptoms include loss of consciousness, low or decreased GCS, unequal pupils, seizures, persistent vomiting, worsening headaches. Get them out quickly. That injury may be survivable if we can get them to definitive care in time. Moving on to airway management in evacuation care. The guidelines here are very similar to those in indirect threat care, with an increased emphasis on the need to definitively manage the airway. You should have options at that point, with additional supplies and personnel. You can consider rapid sequence intubation here or use of video laryngoscopes for intubation. If it is within your protocol and scope, surgical cricothyroidotomy can be performed here for definitive airway management. Mass casualty scenarios make it difficult to maintain and monitor an advanced airway. If you are going to place an endotracheal tube, use an end-tidal CO2 tracing or monitor, if available, to make sure that the tube is in place and stays there. Capnography waveforms allow for rapid and definitive management of airway in the field. Monitoring end-tidal CO2 gives excellent information on respiratory status and the patency and adequacy of the endotracheal tube. If it is available and in your protocols, use it. Intubated patients that are placed on mechanical ventilation, such as transport ventilators, should have lung protective strategies initiated. Manage these patients with lower tidal volumes, lower airway pressures, and PEEP valves to maximize air exchange, and of course, closely monitor any intubated trauma patient for development of tension pneumothorax. TECC emphasizes only immobilizing those who truly need it. Not only does current evidence in EMS point to over-immobilization, spinal immobilization greatly increases the amount of resources any one patient needs. As a whole, spinal immobilization should be initiated based on your agency protocol. If selective spinal immobilization is in your protocol, evacuation care is where it should be applied. Remember, the C-collar and the backboard are not magical devices. They're just tools to limit movement. Be creative during evacuation care. There are a variety of ways to limit movement that do not require a C-collar or backboard. Talk to your medical director. Use your scope of practice and your protocols and answer the question, if immobilization is indicated, how can we achieve our goal of limited spinal movement in a resource-limited environment? For management of breathing during evacuation care, again, the focus is more on maintaining respirations than on making a patient breathe. Watch for development of tension pneumothorax or any indication for chest decompression, which may be as simple as increasing respiratory distress in the casualty with a chest wound. As supplemental oxygen should be available in evacuation care, any altered pulse oximeter readings should be addressed with oxygen. Not every patient needs oxygen. Oxygen, although likely available, is still a limited resource. Only apply O2 when needed. Any patient in shock, any patient who is hypoxic, unconscious casualties, TBI patients need increased oxygen. Casualties with chest wounds, go ahead and fill their lungs with oxygen. Most bleeding should have been addressed by this phase of care. However, because things change and interventions fail, all wounds should be fully exposed and re-examined for unrecognized or continued bleeding. At this point, minor bleeding can be addressed if resources are available. Think about tourniquet downgrades here. Depending on length of time until evacuation and on tourniquet effectiveness, a prior placed tourniquet may be downgraded. This picture illustrates the complexity and pattern of injury in the typical blast patient. There is a multitude of wounds to deal with: abdominal evisceration, multiple penetrating traumas from fragmentation, obvious fractures, and amputations. A damage control resuscitation approach maximizes the ability of this patient to live. Damage control resuscitation is a new strategy in trauma resuscitation that is based on addressing the lethal triad in trauma: coagulopathy or abnormal clotting, hypothermia, and acidosis. It is a targeted resuscitation to address what we know about the physiologic response to trauma. The lethal triad looks like this. Injury causes bleeding. As the patient bleeds and begins to go into hemorrhagic shock, multiple harmful physiologic processes are put into motion. To start, injury causes bleeding, and bleeding, if uncontrolled, leads to hypoperfusion. Once the patient develops hemorrhagic shock on a physiologic level, there is tissue-level hypoperfusion. Tissue hypoperfusion creates cellular hypoxia, which forces the cell to anaerobic metabolism. Anaerobic metabolism produces lactic acid, creating a state of metabolic acidosis in the body. And acidosis decreases the body's ability to clot. If the patient does not clot, he or she continues to bleed. And if he or she continues to bleed, well, all bleeding stops eventually, and the patient dies. Studies show that metabolic acidosis decreases the platelets' ability to stick together to form a clot. So you want to prevent hypoperfusion, because when you prevent hypoperfusion, you prevent acidosis. Injury leads to hypothermia. Not only is exposure after trauma an issue, but hemorrhagic shock induces hypothermia as well. The anaerobic metabolism induced by cellular hypoperfusion is inefficient in production of energy. It is a stopgap measure to keep the cell from dying, and the kilocalories of heat that are produced by this process is only a small fraction of what is created by normal metabolism. Therefore, the body in shock cannot compensate for any external cold stress, and even without external cold stress will eventually become hypothermic because heat production is ineffective. So, uncoupling of the normal metabolic pathways makes the generation of body heat inefficient. Not only that, the injured patient lays on the cold ground, maybe gets wet if the ground is wet or the sprinkler is on. Then rescuers pull the victim outside, expose the injuries by cutting off the clothes. Room temperature IV fluids are started, and the hypothermia worsens. Trauma patients quickly become hypothermic just from exposure and what we do to save them. Hypothermia is linked to death in the trauma patient, and studies show that if a trauma patient drops to a core body temperature less than 90 degrees, there is a 100% mortality. Even moderate hypothermia affects coagulation. Poor coagulation and platelet function means that the patient does not stop bleeding. The victim continues to bleed, and as we all know, all bleeding stops eventually. Last but not least, in the severely injured patient, the trauma alone may lead to a state of coagulopathy, meaning a state of abnormal clotting where the victim is unable to stop bleeding. There is something called the acute coagulopathy of traumatic shock. In trauma with massive tissue damage, the body actually becomes coagulopathic on its own. We used to think that this state of abnormal clotting was because of the resuscitation, that we pumped you full of IV fluids, replacing blood with fluids that diluted your own ability to clot. Although this is true, it has recently been found that the chemicals released by the damaged tissue create a state of abnormal clotting in and of themselves, just from the trauma alone. It is a very complex process that does not occur in every trauma patient, but if it exists, this coagulopathy certainly causes a problem. If you're coagulopathic, you don't stop bleeding. If you don't stop bleeding, well, all bleeding stops eventually. So what you need to remember about the lethal triad: acidosis causes abnormal clotting, which increases bleeding, which leads to death. Hypothermia causes abnormal clotting, which increases bleeding, which leads to death. Coagulopathy is abnormal clotting, which increases bleeding, which leads to death. So how do we address the lethal triad? The emphasis in damage control resuscitation, whether it be in an indirect threat care phase if the tactical situation allows it, or whether it's in the evacuation care phase, is to: number 1, recognize and prevent hypothermia. Number 2, prevent the development and worsening of acidosis. And number 3, do the best we can to correct the abnormal clotting. Hypothermia prevention was discussed in the indirect threat care phase, and certainly in the evacuation care, there should be blankets or other warm cover to prevent heat loss, and we should be able to get people off the ground. Prioritize hypothermia prevention. Use whatever you have to prevent conductive and convective heat loss. And certainly use warm IV fluids if available. Shown here is the APLS stretcher. It is a lightweight, poleless litter that is also a vapor barrier, providing thermal retention and absorbing body fluids. These are deployed on the mass casualty units throughout Northern Virginia. They are helpful if available, but you don't have to have one. Be creative. Use what you have available. Tarps, blankets, jackets. Avoid placing patients directly on the ground without a vapor or conductive barrier. Out of the three parts of the lethal triad, coagulation is the most treatable. One of the potential medications to treat coagulopathy is tranexamic acid. Let me clarify that although tranexamic acid is discussed in this training, the use of this chemical must be based on your agency protocols and your scope of practice. Tranexamic acid, or TXA, is a lysoamino acid derivative that has the physiologic effect of preventing existing or developing clots in the body from being broken down. Unlike other hemostatic drugs, this one does not make you clot, it just prevents your system from breaking down clots. The human body is always in balance or homeostasis. After traumatic injury, as your body starts to make clots to stop bleeding, a counter process also begins to break down clots, limiting the extension of the clot that is forming from propagating throughout your body. TXA prevents this process. It prevents clots from breaking down. TXA is not a new drug. It has been used since the 1950s in OBGYN for women who have heavy menstrual periods and for heavy postpartum bleeding. Recently, 2 large combat studies have shown that penetrating trauma and blast patients benefit from the use of TXA, increasing survival if the drug is given soon after their wounding. There are some specific nuances about the use of TXA. The survival is greatest if the drug is given within 1 hour of injury, and the drug shows benefit if given up to 3 hours following injury. However, it must not be given more than 3 hours after injury. The studies showed a worse outcome in patients who received the drug in a delayed fashion. It's certainly worth looking up the evidence on TXA and discussing with your medical directors. The 2 main studies in the trauma population are the CRASH-2 trial and the MATTERS trial. There are ongoing regional discussions whether or not this drug is something that we should be employing in mass casualty, where there may be a delay in getting the patient into the operating room, and several regional agencies are already giving the drug in selected trauma patients. Fluid resuscitation in evacuation care is based on the concept of damage control and hypotensive resuscitation. Current research shows that aggressive fluid administration in trauma to a goal systolic pressure of 120 or 130 millimeters of mercury may have negative effects on trauma patients. Instead, fluid resuscitation in mass casualty and resource-limited scenarios should be based on damage control and hypotensive resuscitation principles. Instead of a systolic blood pressure goal, the endpoints for hypotensive resuscitation in patients without traumatic brain injury is to improve level of consciousness and maintain a radial pulse. Over-resuscitation, especially in patients with internal bleeding, worsens coagulation by diluting clotting factors and may actually increase blood pressure to the point that formed clots may be dislodged. To reiterate, similar to the guidelines of indirect threat care, if the patient is not in shock, no IV fluids. For patients with delayed evacuation, if they are conscious, can maintain their own airway, and do not have injuries that would require emergency surgery, fluids given by mouth are okay. For patients in hemorrhagic shock without head injury, the initial fluid resuscitation strategy is 500 cc boluses of whichever fluid is in your agency protocol, normal saline or lactated ringers, to maintain a palpable radial pulse and to improve mental status. However, if the casualty has an altered mental status because of traumatic brain injury, the goal for fluid resuscitation becomes a systolic pressure of 90 to 100 millimeters of mercury. The need to maintain critical brain perfusion takes precedence over any downside of over-resuscitation. And certainly in this phase, you should have the ability to monitor their blood pressure. So the goal for TBI patients is to maintain a measured systolic pressure of 90 to 100 millimeters of mercury. Next, Monitoring. Certainly, during evacuation care, monitoring is something you should have the ability and resources to do. If available, this is where you should obtain true measured blood pressures, oxygen saturations, and tidal CO2. If you have the resources and the patient's condition warrants it, you could do an EKG. Let me emphasize that these measurements should all be recorded. Good record keeping is key, and that should be forwarded with the patient. Pain control should not be ignored, especially in evacuation care. You should have multiple options for pain control in this phase, and given the increased resources, should have more ability to deliver opioids. If approved by your protocol and scope of practice, the TECC guidelines encourage the multimodality analgesic approach. This is a strategy in which multiple types of pain medications are delivered together. These medications potentiate each other, so lower doses can be used with greater effect and less side effects. Northern Virginia agencies are using ketamine as a sole agent or part of a multimodal approach. Another option, although not in use in our region, is the transmucosal fentanyl lollipop. There are many options for analgesia in evacuation care. This is a topic that is worth discussing as an agency because the mass casualty or resource-poor environment is not an excuse to undertreat pain. As detailed patient monitoring may be difficult at best, the prudent approach may be to move away from using morphine at high doses with its associated dangerous side effects and consider new approaches and new medications. Burns should also be treated in the evacuation care. With burns, the treatment approach is the same as it is in indirect threat care, with additional emphasis on aggressive airway management. Consider early application of definitive airway control for the patient with any signs of significant airway thermal injury. Aggressive treatment for carbon monoxide and cyanide in any smoke inhalation patient is also emphasized. For transport vehicles, especially non-traditional ones, be aware of the risk of off-gassing of smoke, cyanide, or other volatile chemicals. The main consideration from smoke inhalation, besides carbon monoxide, is cyanide toxicity. Cyanide gas, a common product of combustion, interferes with the cell's ability to metabolize oxygen. This forces the cell to switch to anaerobic metabolism, an inefficient energy system that creates large amounts of lactic acid. It is rapidly fatal, affecting the highly energy-dependent heart and the brain the most. The problem with cyanide toxicity is the inability to use oxygen, not a lack of oxygen. So, as there typically is plenty of oxygen in the blood, the pulse oximeter measurement may be normal, even in severe cyanide toxicity. The TECC guidelines recommend treating cyanide toxicity aggressively in the evacuation care phase. In the National Capital Region, although it is not the only treatment, hydroxycobalamin or cyanokit is the most common treatment modality. Hydroxycobalamin is a vitamin B12 precursor that binds with the cyanide molecule in the blood, creating a non-toxic compound called cyanocobalamin. As the cyanide molecules are bound, tissue cells are able to begin to utilize the available oxygen. Hydroxycobalamin is a safe drug. When it is administered, it may cause a small bump in the blood pressure, and it will cause the patient's skin to appear flushed. Although cyanokit is expensive, it is life-saving. The TECC indications to use cyanokit are based on the Paris Fire Brigade protocol. The Paris Fire Brigade has been using hydroxycobalamin for many years and have an impressive smoke inhalation save rate. The indications to give a kit are known smoke exposure in an enclosed space, altered mental status, and signs of smoke inhalation such as soot in the nares or in the mouth. According to data from the Paris Fire Brigade, aggressive treatment for cyanide exposure using the indications just discussed can result in a 50% return of spontaneous circulation in patients removed from fire in full cardiac arrest. For those in cardiac arrest not associated with smoke inhalation, unlike other phases of care, CPR may be attempted in evacuation care if the patient does not have obviously fatal wounds and there is a short transport time to a trauma center. Remember that CPR is time-consuming and very resource-intensive, with an extremely low success rate in victims with traumatic arrest. As such, it is certainly okay not to initiate CPR, and CPR should never be done at the expense of the mission or if it takes resources or personnel away from other casualties. One consideration, however, is that in traumatic arrest from penetrating trauma, tension pneumothorax may be the underlying cause. It is very hard to recognize tension pneumothorax in the dynamic mass casualty. In evacuation care, if someone is in full cardiac arrest, it is reasonable to do bilateral needle chest decompressions to empirically treat tension pneumothoraces prior to complete cessation of care. Finally, other considerations in evacuation care are the use of atypical platforms, such as police cruisers, for rapid evacuation. This is exactly what occurred in the Aurora Century 16 shooting. All of the initial patients and half of the overall transports were in the back of a police car. Consideration of alternative transport of course requires conversations with your law enforcement partners. These conversations must occur ahead of game time, whether you would consider alternative transport or your jurisdiction would never allow it. The worst thing you can do as a first response agency is to put your head in the sand and say, it's not going to happen here. Police officers transporting wounded patients have occurred in a multitude of places. The final point in evacuation care is to emphasize medical record keeping. Data in mass casualty shows that field medical records are inconsistent at best. We know this is difficult, so the TECC guidelines specifically mention record keeping as a way to put emphasis on the need. Find an efficient medical record that captures the appropriate medical information regarding the field TECC interventions, and forward that information with the patient to the trauma center.